Okay, I think we shall start with our next talk. I think this is kind of a lighter topic compared to the previous talks by Dashraf and Dr. Paul. So I think you can relax a bit and just go along as we talk about liberation from mechanical ventilation. Or rather, the more simpler term I would like to call it is just weaning. From here now, I will call it weaning from mechanical ventilation. Okay, so first of all, we look at why we want to wean a patient. Why is it important to wean someone from mechanical ventilation? The definitions of weaning. How do you wean? What are the causes of failure to wean, and the conclusion with that? I'll go through some case scenarios after that as well, and we have our references. So why do you want to wean someone from mechanical ventilation? Okay, so number one, because it's the objective of ICU care, right? You bring someone in from the wards or from emergency department after they are intubated, and your objective is to wean them from ventilation. Patients can be discharged. Usually, the objective is to wean them, and then they can be discharged from ICU. The duration of mechanical ventilation actually affects their mortality, their outcome, and you will frequently come across this term called ventilator-free days (VFD) in multiple trials. So it's an endpoint of the patient that comes into ICU. So that's one of the objectives for why you want to wean the patient. And the second one is mechanical ventilation comes with multiple complications. It's deemed to be a necessary evil. So as much as possible, you don't want to intubate a patient, right? But sometimes you have no choice, so it's a necessary evil. You have to do that. And complications can be from the ETT, from the procedure during intubation, can be from the sedation and the hemodynamic effects post-intubation, can be from respiratory infections, and it can cause post-ICU syndrome as well, as they are in prolonged ventilation. One thing to highlight is ventilator-induced diaphragmatic dysfunction. It occurs as early as 12 days after someone has been intubated, and diaphragmatic muscle thinning happens at 6% per day. And this is the frequently quoted number in a lot of the studies. So weaning failure also is associated with mortality. Every failed extubation increases mortality exponentially as well. So with all these points, that I hope you can understand that why we want to wean someone from mechanical ventilation, what's the importance of that. So next, we move on to definition of weaning. For those of you that have babies, you may be very familiar with weaning. There's traditional weaning and elect weaning. So this is a different kind of weaning, and again, there are definitions as well. So the definition of weaning, actually up to current date, there is still no kind of agreed consensual definition of that. But we do kind of have an agreement that weaning equals separation attempt from mechanical ventilation. That includes SBT or no SBT plus minus extubation of a patient. In 2007, there was an international consensus, but this is not a definition of weaning, it's just the definition of weaning process. So you have simple weaning, whereby one time, first attempt, patient can be extubated without any complications. This would most likely frequently be your patient in OT electively intubated for the procedure, and they are done and intubate them first attempt, no issues. So the second group would be those that are considered difficult weaning, whereby they require up to 3 spontaneous breathing trials, or they have been ventilated for as long as 7 days before they are able to be weaned. And the third one would be prolonged weaning, more than 3 or more than 7 days. So basically, the classification of it, simple, 70% of your patients will be in the category of simple, difficult 15 to 20%, and prolonged would go up to 10 to 15% as well. Yeah. So next is how do you wean the patient from mechanical ventilation then? How to win friends and influence people. Okay, this is not how to win friends and influence people. This is how to win from mechanical ventilation. So basically, this graph or this chart shows all the steps that are involved in it. First one is to treat the cause of acute respiratory failure. Secondly, then you assess readiness to wean. And then the third step is you perform your spontaneous breathing trial. And the fourth one is the actual step of extubating the patient. And this has been kind of similar in our CPG, our ICU protocol as well, whereby the first step is whether the resolution of the disease has been done or not. If yes, you can proceed to wean a patient, but if no, you have to go back and review back and we consider your treatment options. So again, that's the first step, and then the second step, you would think whether patient is ready to be weaned or not. And the third one will be going on to a spontaneous breathing trial. And there are subsequent others as well in between, and the final sort of step is to proceed with extubating the patient. So again, I'm repeating myself here. There are the kind of four main steps to weaning a patient. Number one is the cause for mechanical ventilation. Has it been resolved or at least partially resolved to the extent that you are able to wean the patient? And secondly, then you assess the readiness to wean. You do a spontaneous breathing trial and proceed with extubation. So let's go into a bit more detail about these steps. So number one, the cause, whether it's resolved or not, largely that depends on the underlying diagnosis and the severity of what the patient came in with. Yeah. And it's kind of categorized into sort of respiratory and non-respiratory causes. So your respiratory causes would be, as stated previously by Dr. Ashraf, Dr. Paul, say someone with asthma, coming with asthma or COPD, clearly that's a respiratory cause, right? Coming with pneumonia, ARDS, those are respiratory causes as well. So non-respiratory cause frequently would be those that are intubated for heart failure, fluid overload from a CKD, decompensated heart failure. If they are coming with DKA, it's a metabolic sort of cause. So those are the non-respiratory causes. And then you can also categorize them infectious or non-infectious one. The main thing is because infection, if there's a pneumonia, there's a patch there, you wouldn't resolve so fast. If that to the extent that patient is in respiratory failure requiring ventilatory support, you don't expect like one day of antibiotics miraculously suddenly it will work and patient will recover that fast, right? Your antibiotics take time to work as well, and you're not sure whether you're hitting with the correct antibiotics or not for the patient also. So most of the time, in general, kind of really general, infectious causes may take a longer time. Non-infectious ones, things like fluid overload, you offload them, they can be weaned fast. Okay, so that's faster. And you have to think of your treatment, whether it's accurate, whether it's efficacious or not, and the duration of your treatment. So next step, the second step after that is to assess the readiness to wean. So we say that it should be always suspected early whether this patient is ready to be weaned or not. So the first time the patient comes into ICU on your initial clocking alone, in your ICU admission clocking, you should be thinking, how soon can I wean this patient? Is this a fast one? Can I wean within the next 24 hours, or will this patient require a longer duration of time? So it should be considered and suspected early. Because if the patient, once they step into ICU and they're ready to be weaned, you can immediately turn off their sedation or turn down their sedation and assess them for weaning the next day. There are subjective and sort of objective criteria whether patient are ready or not. So the subjective one would be by your kind of assessment whether the resolution, the disease is resolved already or not. Patient has adequate cough or not, and whether they have excessive secretions or not. So those are kind of subjective measures, right? You have no actually parameters that or no objective way to measure that. Then the objective sort of criteria would be their level of consciousness. So this is by RAS score, their GCS assessment. Respiratory part, the PF ratio, generally we say if PF ratio is more than 200 and they're on a PEEP of less than 5 or FiO2 is less than 0.5, you think that they are ready. Adequate pulmonary function, don't really have a way to measure actually at this point. Hemodynamic stability also is another thing. If they're on high NORAD dose or they're on double or triple pressors, they're not ready yet. Metabolic status, more frequently it's those that come in with DKA, their acidosis, has it resolved or not, or their kidney or renal failure patients, whether their uremia under control or their electrolytes. So those are the points to consider, right, for your assessment of readiness to wean. So the next step after that is performing your spontaneous breathing trial itself. There's a lot of significant heterogeneity and methods to do the spontaneous breathing trial. And can be done with minimal or no ventilator assistance, or can be done with a T-piece. Duration can be 30 minutes, anywhere between 30 minutes to up to 2 hours, 120 minutes. The ones that you would prolong, you would move up to 2 hours to be those patients that are high risk of reintubation. Say you have a 80-year-old elderly gentleman, you know that they're not so strong, they can't even lift their hands. So you are a bit concerned, you want to prolong the SBT, you might want to prolong SBT for them. Those with heart failure or some neuromuscular disorder, so you would want to prolong their spontaneous breathing part. And the monitoring in the initial part when you start the SBT is really important because you need to decide whether this patient, is it safe to continue your spontaneous breathing trial or not. Say when you put the patient on SBT and they're tachypneic, they're tachycardic, they're in respiratory distress already, then it's already, that it's a failed SBT. They cannot continue any longer. So no point dragging on up to 2 hours in those cases. So there are like different forms of spontaneous breathing trial. You can either use just a low CPAP level of 5. You can have low pressure support levels also of 5 to 8 as well. You can have slow triggering with no pressure support at all. And you can disconnect from the ventilator and put a T-piece for breathing, for the spontaneous breathing trial. So looking at spontaneous breathing trial, this was quite a few years back, published in New England Journal in 1995. They compared 4 methods of weaning from mechanical ventilation, and this is from the Spanish lung failure group that compared that. The first method they used was intermittent mandatory ventilation, so your SIMV. They set a low rate though. They just put a rate of 10, SIMV rate of 10, and that's their SBT. Okay, the second method is pressure support. They allow up to 18 plus minus a PEEP of 6. Okay, so the PEEP is kind of optional, but the support can be quite high, can go up to 18 for their trial. And they can have intermittent trials of EPs or CPAP with a PEEP of less than 5, and once daily trial of EPs only. So these are their results of probability of success of weaning on the y-axis here. So meaning the graph, the two lines at the top here give the highest predictor or highest success of weaning a patient. So these two lines are the ones intermittent trial and the ones it's the intermittent trial and the once daily trial, meaning they use the lowest support. The intermittent trial is the one with the T-piece or CPAP of 5, and the once daily trial is with the T-piece only. So going on the lower, seems like going on a lower support or lower sort of settings increases the probability of successful weaning for them. To put it this way, if you're putting more strain on the patient to breathe on their own, actually increases the probability of successful weaning them. Okay, so logically it makes sense that you have them less dependent on the machine. Patient will try to breathe more on their own, spontaneously more. Then there's a higher chance of weaning them, right? So SBT failure. Okay, so this is not weaning failure, but really SBT failure. So when you put someone on a spontaneous breathing trial, there are three kind of methods you can detect whether you can continue on the spontaneous breathing trial or you should abort it at that point. So the first one, based on clinical criteria, is if their respiratory rate goes up to more than 35, you shouldn't continue. If they have evidence of increased work of breathing, increased inspiratory effort as well, you shouldn't continue looking at nasal flaring, respiratory muscle use, abdominal breathing, or intercostal recession. And of course, if they're apneic, also you shouldn't continue on the spontaneous breathing part. So those are sort of clinical criteria for that. The second one of failure for SBT would be vital signs. So if their saturation drops to less than 90%, or there's a fall more than 5% in their SpO2, so you shouldn't be continuing on the SBT as well. You know that it's a failed SBT at that point. So those are SATs. The second part is kind of hemodynamic cardio sort of signs. If they're tachycardic, heart rate more than 140, or increase in 40 from baseline, or there's a variability of more than 20%. If there's any sort of arrhythmias, I think it's not uncommon. I've seen patients put on SBT and they go into fast AF. So that's one of the common arrhythmias that can happen, and it shouldn't continue on with the SBT anymore at that point if that happens. If their blood pressure raises or drops as well, or more than 20% of change in baseline, the rise in blood pressure is actually one of the signs of sympathetic response from the patient's body. So when they have increased sympathetic response, it tells you that they are in distress actually. So don't just give antihypertensive for the blood pressure that comes up. If you put the patient on SBT and their BP rises, you know that they are in stress. They are in some kind of stress, and may not be suitable to continue on the SBT. And lastly, the thing, what we call the rapid shallow breathing index, RSBI. You take the respiratory rate of the patient when they're on SBT divided by their tidal volume, but this tidal volume is in liters per minute that you divide it by, and you get the RSBI. So anything higher than 105, meaning that they are breathing very rapidly, but their tidal volume is very small. All right. So they're not getting enough tidal volume. They're breathing very rapidly. So they're in distress, and you shouldn't continue on the SBT anymore. However, given having said that, because this RSBI is sensitive but not so specific, meaning that if your RSBI is more than 105, you can say that patient will fail. Extubation is a predictor of extubation failure and weaning failure. But if the RSBI is normal or less than that number, it doesn't naturally predict your success rate. Okay, so doesn't mean you'll be successful because as we mentioned earlier, we'll go into later, there are a lot of other factors that come into play when we patient, not just the respiratory rate. Then ABG, commonly our practice would be put the patient on a spontaneous breathing trial and then hit the ABG in 1 hour's time, right? So after that, you would look at it. If the patient is getting more acidotic, pH less than 7.35, or PCO2 increase more than 10 above the baseline, or PaO2 is less than 60, then you know that patient is going to distress and getting into trouble. You shouldn't continue anymore. So kind of the fourth step of extubation. Even before extubation, if the patient passes a spontaneous breathing trial, you still need to assess the patient whether they are ready for extubation or not. And in our ICU protocol, it's recommended to perform a cuff leak test in patients that are at risk of post-extubation stridor. So there are like 1, 2, 3, 4, 5 sort of situations where you would consider performing a cuff leak test. Not to say must, but you would consider performing a cuff leak test in the following patients: those that had a traumatic intubation or intubation more than 7 days, excessively large ETT or mobile ETT, and reintubation after an unplanned extubation. So personally, also I would say that you encounter a post-extubation stridor in patients that are very restless. So they're thrashing around and then their ETT is being pushed all around their airway while they're very restless, and that could cause airway edema upon extubation. So you have to be a bit more cautious for that patient. So in terms of extubation criteria per our ICU protocol, they look at level of consciousness, the cough strength, and the quality of secretions. So this extubation criteria is kind of, there are similarities to your weaning criteria also, but these are the things that to look out for just before extubating the patient actually. So whether they are alert, awake, and they can pass the 4 tasks of tests, obey command. But we say that in traumatic brain injury, GCS more than 8 actually is acceptable when the neurological status is stable. So frequently you will come across TBI patients, even though they are half conscious like that, and you will still be able to get away with extubating them. They may not necessarily need a tracheostomy. Next is the coughing strength. So coughing strength, this would rely on frequently our nurses' assessment. I fully trust them when they tell me that patients' cough and gag is good or cough and gag is strong. They are the experts when they do suction, and they will come across and they are very experienced in assessing whether this patient how's their cough and strength. And the quality of secretion, again, I would frequently rely on our assessment as well. They are the ones doing the suction frequently, and they can tell you how secretions, moderate or large amount, and the frequency. If frequently patient will need suction every 2 hours or less, then you know that may not be able to clear their secretion. So that's the part for the kind of 4 steps for weaning. Then the next part is failure to wean. So what causes the failure to wean? This review article actually covers comprehensively about the ABCs of failure to wean and what you should do in those situations and how do you assess them. But we kind of go through that. Okay, this is another more enlarged thing for that article. Reasons stated for failure to wean, the most common cause are number 1, incomplete resolution of the illness, and the second one would be assessment errors in assessing the readiness to wean. So the assessment of readiness to wean, you really need to examine the patient and be at the bedside to really determine. And the third one for failure is there's a new problem that arises. I'm sure you've encountered that your patient has a new sort of infection that causes a failure to wean them, or they have a new stroke that may not be detected while they have been having all the sedation. So there's a new problem that arises throughout their ICU stay that causes the failure to wean. And kind of all those problems, you can categorize it into four primary sort of systems or mechanisms. So number one is related to respiratory, two is cardiovascular, number three is neurology, neurovascular, psychological, so it's after that, and the fourth part is metabolic or endocrine sort of causes. So again, this chart shows that the respiratory, cardiac, neurological, and metabolic causes, and what are the possible causes. This slide is courtesy of someone. So when we look into the details of the respiratory causes of failure to wean, respiratory causes, they describe it as because there's an imbalance of respiratory muscle workload. So the demand is there, but the neuromuscular capability, patient themselves, they cannot respond to the demand. So there are two factors to that. So whatever causes increased respiratory workload, and the second component is whatever causes a decrease in their neuromuscular capability to respond to the demand. So increased workload can be from increased ventilatory requirements. So CO2 production and dead space ventilation contributes to that. And increased mechanical loads can be from airway resistance. As mentioned earlier, if asthma, COPD, there's increased airway resistance. The intrinsic heat. So if you recall Dr. Ashraf mentioning about putting external heat to help with the counteracting the need to overcome the intrinsic heat to trigger the breath, and reduced lung compliance frequently come ARDS patients, right? They have reduced lung compliance. So all these issues can cause increased respiratory workload and subsequently failure to wean the patient. So again, this table shows causes for increased airway resistance, includes your tube diameter, sputum retention in there, or there's kinking of the ETT. Central airway causes of increased airway resistance also, whether that's related to some sputum plug there, or there's some laryngeal injury or trachea stenosis or tracheomalacia. And then towards the smaller airways will be bronchospasm, your mucosal edema, and again excessive secretions that cannot clear out. So all these things cause increased airway resistance and subsequently contribute to the increased work of breathing. Then the second component, major component, will be reduced compliance. So reduced compliance can be divided into compliance of the chest wall and compliance of the lung. So compliance of the chest wall, then you will see that abdominal pressure. Actually, we probably haven't been measuring as frequently as we would like to. Intra-abdominal pressure and intra-abdominal hypertension can contribute to increased chest wall, reduced chest wall compliance. So how many of you have actually gone and measured intra-abdominal pressure? Do you know how to measure that? There's actually methods to measure. Yeah, that's for another talk, I guess. So if your patient comes in for any abdominal pathology, even an acute pancreatitis or they have ascites, distension in the abdomen from other reasons, can cause elevated intra-abdominal pressure and compromise ventilation. So other things like peripheral pneumothorax, obesity, failed chest, kyphoscoliosis, all that will contribute to that. The second component is the lung parenchyma itself, then that causes a reduced compliance. So most frequently is your ARDS and pneumonia that's going on. Okay, so that's the first part, whatever causing the increased respiratory workload is there. And then the second part would be the patient's neuromuscular capacity cannot respond to the increased workload. The decreased neuromuscular capacity can be from reduced respiratory center output, phrenic nerve dysfunction, or problem with respiratory muscles themselves, which can be from multiple causes like electrolyte abnormalities, malnutrition, critical illness, respiratory muscle fatigue, and VIDD, ventilator-induced diaphragmatic dysfunction. Remember when I said earlier that every day the patient is on mechanical ventilation, their diaphragmatic muscle thins by 6%. So eventually the diaphragmatic muscle may atrophy to the point that they cannot pump or they cannot function properly. So this is kind of CNS related neuromuscular capacity. So in the article, all this respiratory pump sufficiency that's causing the weaning failure, they mentioned, so for increased muscle workload, whether the patient has increased muscle work or not, when you're weaning the patient, how do you tell, how do you assess that? You can look at the flow, you can look at the air pressure, airway, the waveforms of that. You can assess gas exchange, look at dynamic compliance, physics, the resistance. You can do ultrasound to assess that, and you can assess for patency of the tube by means of bronchoscopy, and you can do cuff link test for patients high risk of post-extubation stridor. And what interventions that you can do if they have those increased muscle workload, treating the underlying disease and optimizing the airway function by means of bronchodilation, steroid use. And tracheostomy can help reduce the workload as well because you bypass sort of the upper airway area. If they have reduced neuromuscular capability, so this is slightly more difficult sort of to assess. We don't routinely look at this. You look at your maximum inspiratory pressure, and you look at the diaphragmatic thickness as well, and whether there's we can't do it here, but certain countries that do phrenic nerve stimulation as well. So this is kind of more difficult point to assess, but I suppose the bedside ultrasound is a means that we can use to assess the diaphragmatic thickness change and the descent of the diaphragm, the excursion, the diaphragm can be used to assess that. So what to do about that? Optimizing sedation analgesia, meaning you try to minimize the sedation and anesthesia. Muscle training, we have this thing called inspiratory muscle training. I don't know how many of you are familiar if you have done it before or not. Actually, you can use the ventilator to train the patient's muscle. So basically, you have to assess their maximal inspiratory force or negative inspiratory force, and then you set the trigger threshold to kind of be half of that pressure. So patient has to work harder to trigger the ventilator when they breathe. You put them on a PSC mode, you set the trigger to that higher threshold. They will have to work harder to breathe. So it's kind of an exercise for them, the inspiratory muscle training. We sort of do 5 cycles of that, let them rest and repeat the same thing. But unfortunately, we don't have time to sit at patient's bedside to keep doing that training for them, right? So it's not being routinely done so frequently. Early mobilization definitely helps. If Sungai Buloh is doing the early mobilization program, it helps kind of keep the muscles moving and gains their strength, and it has been shown to be beneficial in helping to wean patients. Minimizing patient ventilator asynchrony is kind of hard. You would have to look at the waveforms and you have to adjust your settings to fit the patient's breathing pattern. Rest if respiratory muscle fatigue exists, there's kind of by your assessment as well. So if you put someone on PSV, put them on pressure support, say you put them on pressure support of 10, and they're breathing at the rate of 30, 35, they will eventually get fatigued. So that's not a training for them. That's just running a marathon for them and training them. So they may not be ready yet. There may be other things you need to treat and do first before you can put them on that. So push up the support. You see that they're barely getting adequate tidal volume and tachypneic on the PSV. You may even put them on a more controlled mode and let them rest for the night. They change them back to SIMV, let them rest the whole night. The next morning, only try again. And providing adequate energy intake is a thing that we probably are not doing well enough because we don't have, how many of you use direct calorimetry? That is the gold standard to measure our patient's energy requirement. We all use our simplified formula of 20 to 25 kilocalories per kg per day, right? But in the recovery phase, actually, they may require higher than that. And adequate energy intake and protein intake, you would say, is important for the muscle recovery. But how much do we need is still a debate. And if you don't have a method to measure, because everyone is different, right? Everyone's basal metabolic rate is different as well. So how much energy they require may be different. You don't want to overfeed them where they will have to work harder to wash out the CO2. But at the same time, underfeeding them, their muscle goes atrophy, they become weaker. So it's hard to get the right balance if you don't have the proper measuring tools. So unfortunately, there's something we still need to work on. So the next reason for failure to wean would be cardiovascular. It's increasingly recognized as an important cause, which up to 59% of patients can have weaning-induced pulmonary edema, what we call VIPO before. And weaning is a strain on the cardiovascular system because there's increased afterload and left ventricular ejection fraction drops because of the increased afterload. They have increased adrenergic tone as well and increased myocardial oxygen consumption. So there's a complex interplay of multiple factors when you wean a patient that puts a strain on their cardiovascular system. So for those patients that don't have such a good heart condition, it may cause weaning-induced pulmonary edema. So this is just showing all the complex interplay why we wean a patient from mechanical ventilation. You can start from anywhere, but I would like to start from increased LV afterload as you wean them. And then it causes increased adrenergic tone, this systemic venous return, and all these things. It can run all over the place. All right. And the endpoint is reduced LV compliance. It can cause myocardial ischemia, increased vocal breathing as well. So for cardiac dysfunction, then what do you do? What can you do? Again, there are diagnostic wise, you can do a 12-lead ECG before and after or during the spontaneous breathing part. You can ask for echocardiograms. You can monitor saturation, venous oxygen saturation. You can measure pro-BNP. And you can consider angiography or coronary catheter. We don't no longer use it now. The other so the therapeutic interventions for that is optimizing fluid balance. So I think now we should go more towards the restrictive fluid management as the patient is going to recovery phase. So you should no longer be pushing the patient positive 5 liters, 10 liters of fluid throughout their 1 week stay in ICU. While they are going into recovery, you should de-escalate. Remember your ROSE phases of resuscitation. So towards the endpoint when you are weaning the patient, it should be going towards an even or less positive balance sort of state. And you can have things to reduce afterload, inotropes or vasodilators. What we like to use would be nitrates actually. I have had patients that have weaning problem and we start them on isodue, something like 10 milligrams TDS of isodue, and actually it helps. It helps them to wean, reduces the stress and burden on their cardiac function. And if there are evidence of myocardial ischemia, of course you need to minimize and treat them. So with the appropriate therapy. Okay. So sort of the third part, neurology. We mentioned earlier neurology as well. Brain dysfunction can be from stroke, can be from delirium or other sort of cognitive disorder. So how do you diagnose them? It may not be easy, especially if the patient is on sedation, but if they're on sedation already, you should assess them by your CAM ICU scoring for delirium and screening for depression, anxiety, and looking at sleep disturbances. And getting enough sleep is really quite important for patients in terms of their cognitive function. And the therapeutic interventions that you can do, we would say that optimizing sedation, including reducing the use of benzodiazepines. Multiple studies have shown that benzos really cause increased risk of delirium, prolonged weaning. So we are moving towards reducing the use of benzodiazepines as much as possible. So no more midazolam together or midamorphine together. As much as possible, you should, if you require them, you should also dilute separately and titrate the doses separately. So providing appropriate pharmaceutical treatment for their anxiety, depression, or delirium help. Presidex increasing also optimizing your ICU environment. I say our ICUs are quite noisy. At least for my ICU, I don't know how is it for your ICU. Frequently, you have alarms beeping around and people coming in, talking, and different teams coming in, right? So there's a lot of noise. So the environment is not really so conducive for their cognitive recovery and for sleep. So all that should be optimized as much as possible. Unfortunately, our resource limitation, the beds are quite crowded, right? If they have a single room with a good view and a nice environment, music playing in the background, that would be really the optimal condition, right? That actually happens in developed countries, that they're able to do that. So the final component of sort of failure to wean would be metabolic endocrine reasons. So this you frequently come across, and I think they are quite straightforward to treat. If there's any electrolyte glucose abnormalities, you should control that. Hormone plasma levels, mainly thyroid actually, that we come across. So if they could have thyroid dysfunction that occurs or that was not picked up prior to their ICU admission or have developed throughout their time. So you should bear that in mind. There are signs of that. The other thing is steroid. If they have sort of adrenal insufficiency, especially if they have history of taking traditional medications. So the signs can be quite subtle. So that you can consider checking the morning AM cortisol level, even though the interpretation may be a bit difficult in critically patients, but that should be in consideration if there are signs of adrenal insufficiency. So again, this is sort of taken from the ABCs of weaning sort of thing, and what is your assessment and intervention to look at what you can do about that, and whether there are more advanced assessments available and advanced intervention for that as well. So for the airway, lung, you can see problem with resistance, compliance, or gas exchange. How do you treat all that? And then for brain, if there's delirium, you screen with the CAM ICU, and then you treat with your reorientation, mobilization, and haloperidol considered. There are other cognitive dysfunction, you can go through that screening and the treatment as well. And cardiac, we've gone through already, so that they're sort of the same things we covered, right? Diaphragm assessment, then it's more complicated. So you find ultrasound of the diaphragm, and you see both of these. Early mobilization is the sort of intervention. So it's really quite important to try to mobilize our ICU patients earlier. And the metabolic part, measuring of the hormone levels, treating appropriately with that. Okay, so those are the kind of main causes of failure to wean. But I always, the other way to remember them is, remember one of my ICU consultants have told us before, it's ABCDEFG sort of causes of failure to wean, right? So A is kind of airway or problem with the airway. B is like breathing, any problems with their breathing, their blood pressure also, whether it's controlled or not. And then C is cardiovascular, all your cardiac problems, can be congestive heart failure as well. And then D is what? Drugs, yeah, drugs, disability related to that. And then E, electrolytes, yeah, electrolytes and endocrine go in there as well. F is fluid. I remember if there's fluid overload sort of condition, it may fail as well. And then G is ghost. Oh, how come you all know this as well? I thought it's only limited to, yeah. So yeah, the one I always remember is G, ghost. Ghost is mainly delirium from there. Okay, so what's the role of NIV in weaning? NIV sort of can facilitate extubation in borderline cases, can help you prevent reintubation in sort of high-risk patients, and can help you to treat post-extubation respiratory failure. So you have extubated the patient already, but they are still in respiratory failure. You may not need to jump to reintubate them and put them on NIV. So those are the roles for NIV. And the potential candidates or those high-risk patients, as mentioned previously, is COPD, heart failure, age more than 65, hypercapnia during SPT, or they failed one SPT already. So those are the use of the patients for NIV. And this flow chart kind of tells you when you will need to use NIV. Say some patient undergoing SPT, but if they're not successful, you may still consider NIV or extubating them to NIV as a facilitation technique sort of thing. So it's recommended for COPD patients with CO2 retention. If they're successful SBT, you can still put them on NIV upon extubation for those with high risk factors, as mentioned earlier, and respiratory failure for curative sort of technique. But then it's stated here there's no evidence of benefit in terms of mortality or intubation rates, except in surgical patients somehow. Yeah, so you remember, as Dr. Paul mentioned earlier, putting them on NIV may delay the intubation. Yeah, so there may not be much benefit because it's just delaying the intubation, but the exception is in surgical patients, you may be able to get away without intubating them, right? And next, HFNC, you have used it more frequently. We almost extubate everyone to HFNC nowadays. We have the luxury of having a lot of HFNC sets left over from COVID time. So HFNC, the evidence is definitely more beneficial than conventional oxygen therapy. Moderate evidence that it's better than putting them on face mask or a laser prong or a venturi mask. Okay, so that's one. But if you compare HFNC and NIV, the evidence is not strong. NIV is still better cases where you need NIV compared to HFNC. Okay, so the evidence is not there to say that HFNC is better than NIV. So that's what we can say by looking at the evidence. And the high-risk patients is kind of similar to the ones you put them on NIV as well. Okay, sorry. Okay, that's my sort of time. Tracheostomy in weaning failure. Okay, so what's the role of tracheostomy? Timing and impact on outcome is still uncertain. We're still not entirely sure when is the best time to do tracheostomy. When patient you try to wean them multiple times and fail. So the thing to take note is the TrackMan trial. For those of you going to the exams, you need to know it's probably the most significant trial looking at comparing early versus late tracheostomy. Early meaning the first less than 10 days of duration. Actually, in the trial, they aim for 1 to 4 days, as compared to the late one where they go on to more than 10 days after mechanical ventilation or they do tracheostomy. But actually, the outcome is the same. There's no difference in outcome. And tracheostomy theoretically reduces airway resistance because you bypass the upper respiratory tract, right? The trachea is further down on the neck. Again, you reduce the dead space, the amount of space from the upper respiratory tract outwards that's involved in gas exchange, and all that contribute to work-out breathing. So those are sort of physiological basis. But probably the important thing is identifying who might benefit from early tracheostomy. So mostly those in the literature, they mentioned that mostly those are the ones that have neurological problems. So your stroke patients or your traumatic brain injury patients are the ones that are most likely to benefit from early tracheostomy. So the conclusion then to wean. So we have gone through the importance, sort of a recap, importance of weaning. You understand the complications of mechanical ventilation, why is it important to wean the patient. Then the next step is the assessment of readiness to wean. So you should try to wean your patients and put them on a spontaneous breathing trial as soon as possible, whenever it's feasible. And looking at the extubation criteria, ensuring that you can safely extubate them. And the four main categories: your cardiovascular, respiratory, cardiovascular, neural, the metabolic, endocrine causes of failure to wean. You need to think about that. Consider NIV or isolated those that are high risk, and tracheostomy is a case by case sort of basis. And ICU liberation bundle is kind of similar to liberation from ventilation bundle as well. So the ABCDEF sort of things, thing that applies when we are trying to wean a patient from mechanical ventilation as well. So assess, prevent, and manage their pain. Do your spontaneous breathing trial. Minimizing the anesthesia and sedation, assessing for delirium, early mobility, and family engagement and empowerment. So all these are important aspects. So these are the references, and that's the end of my finding or weaning. Okay, so kind of just very simple case scenarios. So the first one, you have a 70-year-old lady. Oh, okay, sorry, it's a 70-year-old man, lady. COPD, GO, DM, hypertension, ischemic heart disease, dyslipidemia. Diagnosed right lung adeno-CA 2 weeks ago, complicated with pneumothorax, post lung biopsy. So quite eventful diagnosis. So came into us worsening shortness of breath, acute respiratory failure, intubated. And at that point of time, he had exacerbation of his COPD, and he was in an uric AKI. His ABG, however, didn't show a type 2 respiratory failure. It's a type 1 sort of respiratory failure. CO2 is 25 here. But you can see the bicarb is 13.5 big SX negative 10. Right, and this is its actual X-ray. You can see the lung mass, the right side here. So intubated him, treated him, but we couldn't really treat the lung mass because we are still waiting for respi sort of decision investigation. On day 10 of illness, he's obeying command, not tachypneic. Lungs only has some prolonged expiratory phase. Some PSV, sort of low, or maybe not too low, 0.5, pressure support 10 saturation 96% under those settings. Bear in mind that the family said before coming to the hospital, his saturation was like 90% on the room at home. So he was okay with that. So he was still awaiting for some gene sequencing for the adeno-CA, so they couldn't start treatment yet because they want to determine what is the subtype of that. So no chemotherapy was given. So the discussion then now is, what is the next step? What do you want to do for him then? Do you keep him intubated until he gets the chemo or some immunotherapy? Or do you extubate the patient at this point because he's obeying command Jesus full kind of low settings also? You want to skip straight and proceed for tracheostomy? You want to do all of the above? You can't do all of the above, right? So how many of you will want to do a show of hands? Nobody wants to keep him intubated. There's no right or wrong per se. Okay, this is a discussion, so don't worry about. I would do A actually. I want to do A for him. B, just bite the bullet, extubate him. Okay. C, proceed with trachea for him. Okay, a few hands of that. Okay, so none of the rest kind of don't know what to do, or you want to do something else, right? Actually, yeah, there was something else that we were planning to do also. We were planning to talk to the family and discuss with them because his lung mass is still there. You extubate him, there's a high risk of failure, right? Because the lung mass is still there. Then if you extubate him and fail again, reintubating him may cause more complications and more problems. So maybe the patient doesn't even want to be reintubated if he's extubated. His lung CA, looking at the X-ray, looks quite advanced already. Maybe a stage 4 lung CA, there may not be any curative treatment available for him. So right. So the other option is talking to the family and then discussing with them about possibly just one-way extubate him and not to reintubate him in this situation. If they agree, and this patient himself also agrees for this. So if you want to wait, how long can you wait? Because the testing, given our setting, it takes a very long time until he gets any chemo. So it's a bit difficult. So there's no absolute right or wrong answer. Trachea can be considered also if the family support is good and they really feel like he will have a good chance of recovery depending on the stage also. Unfortunately, we don't even have a staging of the CA at this point. So it's not so straightforward in terms of how we want to win this patient. Okay, so that case is just to illustrate that. So second case, 50-year-old lady, underlying hypertension, obesity, OSA, diagnosed interstitial lung disease quite recently, electively intubated for bronchial alveolar lavage. She had a recent travel, came back, shortness of breath worsening. So the respiratory failure, we don't know the exact cause. It can be progression of ILD. It can be due to opportunistic infection because she's on immunosuppressant for the ILD. It can be from a pulmonary embolism, as mentioned, because she had a recent long distance travel. So day 2 of mechanical ventilation, the previous day when she was intubated, required high FiO2 setting, required paralysis because she was just very fighting the ventilator and in severe ARDS, to say that. And as you recall in Dr. Paul's talk, early paralysis can be considered in certain patients, although by the end of the day, it will not affect the outcome. Then day 2, already off paralysis and all that, she was already off in command, but was still restless, biting ETT, RR of up to 45 per minute, and saturation 78 to 82% under FiO2 of 0.6 only, right? So, yeah, her blood pressure is supported, not too tachycardic. So the issues with her at this point is the primary problem is not resolved yet. I mean, based on this, I think you all agree she's not ready to be weaned, right? She's not even ready, right? Because the primary problem is not resolved yet. She still has a high oxygen requirement, saturation is low, it's still tachypneic, very tachypneic. So, yeah, we can all agree she shouldn't be weaned, but actually she was weaned to NIV because dramatically failed. Third case, okay, we go through it. 22-year-old man, no non-medical illness, came in MVA, blunt abdominal injury, post-op for small bowel perforation with some primary anastomosis, colon perforation also had the repair done, double barrel stoma. Day 2 post-op is completely obeying command, but RR is about 10 only. So on PSV, RR 10 only. But the saturation maintained settings is quite low. He's still on morphine, 2 milligrams per hour. But he's still having pain in the abdomen on movement or deep inspiration. He complains of pain score up to 5 out of 10. So what would you do for a patient? You off morphine, extubate to NIV, off morphine, extubate to HFNC, off morphine, extubate to nasal prong, wait for another day, or none of the above, you want to do something else. Show of hands for off morphine, extubate to NIV. Oh, no, I'm okay. Yeah, I mean, he had small bowel surgery. You're a bit worried. Your surgeon would be concerned if you extubate into NIV, right? Okay. Off morphine, extubate to HFNC. Okay, I mean, you can consider that maybe. That's kind of a maybe. See, off morphine, extubate to nasal prong. Again, is another maybe also, right? Wait another day. Wait another day for what? You would need to wonder. So none of the above. What do you want to do? As an anesthetist, not an anesthetist, but as an anesthetist, you as an anesthetist, what do you want to do? You want to optimize the pain. That's right. Yeah. So you either get him a PCA or you do something for his pain. What we did is we did a trans-abdominal pain block for the pain because we had limited PCA. So after that, took off the morphine and extubated him to nasal prong. Actually, he didn't even need HFNC because there was no lung pathology. His lung was completely fine. But extubating to nasal prong, then we ensured that he's able to do the incentives spirometry because of the post-abdominal surgery as well. Sometimes there might be some splitting of the diaphragm from the abdominal pain. So you need to ensure that he is able to ensure adequate optimization of his pain control. So that's all for the scenarios.